Hello and welcome again to another edition of the Osteopathic Lyceum podcast. At the time of filming this, the previous weekend, which is early November of 2025, was at the OIA, or the Osteopathic International Alliance conference downtown Toronto, which was hosted in conjunction with the OAO, or the Ontario Association of Osteopathic Manual Practitioners. If I have made any mistakes in those acronyms, please excuse me, I apologize. The OIA conference is, and this is the first OIA conference that's occurred, and I didn't actually know that until I ended up there. The aim is to have discussions within the profession of osteopathy worldwide to come to some form of agreement or some form of standardized approach or shared approach to the profession. Now, the opportunity to argue for and against that is present for anybody. What I will say is that there are definitely people from multiple countries heavily involved in this process. They are skilled people, they are well-meaning people, they are seemingly well prepared with respect to the international environment and their more local environments. There is definitely movement of osteopathy around the world more into the traditional institutional setting as it stands. And you can argue for or against that. The president of I think the proper term is president, or maybe the director of the New Brunswick College of Osteopathy. Again, please excuse me if I make any mistakes with names. Ian Moran was there. So New Brunswick is the first province in Canada to have gotten to regulation. And so Mr. Moran was there representing New Brunswick, and he answered questions quite well. And many of the answers to the questions is we don't know, or we're working on it, because it's, as of November 2025, quite fresh. The things that I want to talk about in relation to that is just some themes that I see developing. Now, the first theme and the thing that drew me to the conference was the theme of competency. With my background and getting my master's in health science education from McMaster University here in Hamilton, Ontario, the term competency just immediately catches my attention, especially in relation to the educational documents that already exist with respect to osteopathy, whether it is in Canada or around the world. So there's a European document, the CEN document, and then the CSA document, which is the adaptation of the CEN document for the Canadian context. The term competency can be used colloquially, or it can be used in a more technical sense. So far, broadly, in the ways I'm able to observe, I think it's being used a little bit more colloquially, which is definitely a move in what I think is an appropriate direction. The idea of a competency can turn into a word salad that is aspirational. So often when you read competencies in documents, it seems like there is not appropriate identification of an observable construct that can be measured. So the thing with a competency, whether you term it competency or EPA, entrustable professional activity, it has to be something that can be observed and measured, or else you can't appropriately say that it has been met or not. So anything that is going to be measured is a discriminatory act, or an act of discrimination. Something is or it is not this thing. This thing must be an identifiable construct. So it must be its own thing and not anything else. I find in most cases that is not what is happening with the competencies that I've been able to observe. The one exception to that, so far as I can tell, is the NBOME, the National Board of Medical Examiners, competencies out of America with respect to essentially the COMLEX series, or I don't actually know how to break down the COMLEX acronym properly, but it's the equivalent to the USMLE series for MDs The level 1 is your basic sciences, and level 2, level 3 goes on. The difference with the osteopathic assessment series or the COMLEX series is that there is the addition of actual manual methods. So within the USMLE series or within medical licensure series, there's going to be physical exams and things of that nature, and OSCEs and whatnot. And the OSCEs do exist. Objective structured clinical examinations do exist within the COMLEX series. It's just that there is the focus on the osteopathic manual methods. So the NBOME document has observable constructs which can be measured and therefore termed competencies. I have spoken before on some of the challenges that I have with respect to some of the competencies because they're based on previously named osteopathic systems, which I do not think are appropriately different enough to be called constructs. They are so similar in many cases that it would be hard to tell if somebody is doing one or the other. So if you look at LAS, BLT versus strain counter strain on some levels, or say maybe it would be more accurate to say LAS, BLT versus functional positional release. You'd be hard pressed in some ways to tell which one is the difference. And the argument would be, well, one has the some of the activating force first, and one has some of the activating, especially passive activating force second at the end. So you can make the argument. I'm just not sure that I buy it appropriately due to the variance between patients and how you have to apply differently patient to patient. So I think a more appropriate construct is an indirect method or a direct method, right? Direct barrier or indirect barrier method. So I think those are appropriately standalone constructs, whereas in the NBOME document as it stands, there is specific technical differentiation of previously named systems. So for whatever it's worth, I have an argument for, say, a more abstract construct or a construct that would apply better to patient care, in my opinion, or in my rationale, versus what stands in the NBOME. Now, I will commend the NBOME document because with those previously named systems, there are standardized resources that can be accessed by everybody who would be challenging the COMLEX series, such that they have a resource that's available for fairness that they can work with, study with, and be tested against. So on that level, that is actually quite reasonable, quite fair, quite strong. So central point with that riff is competency as colloquial and word salad, or competency as clearly demonstrable, observable construct that is itself and is not something else. One of the challenges with any form of competency is how do you measure it? And the reason that's a challenge is because often people don't appropriately pull apart the constructs such that they have something to measure, or even realize that it is or it is not measurable. So assessment requires validity, right? So are you testing the thing you say you're testing? Say with respect to a variety of indirect osteopathic systems, are you sure you're measuring the right thing? The things that you can measure are outcomes. So you can measure, did something change? Now, the thing that is fair to measure with respect to change is going to be movement, either on a gross scale or on a micro scale. It is not fair to measure subjective change in patient because the patient reports are known to be variable enough that using that as a scale to figure out whether a learner or a practitioner did what they were supposed to do, it's not going to give proper insight because the subjective report is variable. So to figure out a way, and with some value judgments or some axiological judgments, to know what you even want to measure. So if you are attempting to measure something like effectiveness needs a pre and post, and you want to use movement, not subjective, right? So you want to use something that is as objective as it can be. So you could use a goniometer, but even there, your results are so variable with respect to different individuals and hands-on treatment with respect to the amount of change that can be expected or can be gained, probably not the most appropriate. If you want to, but you want to see a pre and post, right? So some change in movement quantity, possibly quality. Quality is harder to argue for, but you can have the discussion. With respect to patient safety, osteopathy fundamentally has the barrier concept. I claim that the barrier concept guides you in helping avoid protective responses in the patient. So if you measure the absence of protective responses, so no abrupt movements or noises in response to practitioner movement, then essentially you can have a strong level of confidence that the practitioner isn't engaging those protective responses in the patient, right? So you're essentially measuring the absence. You can set a threshold beyond which the presence of protective responses is a disqualifier, right? So, you set your gold standard is 0, maybe your acceptable standard within an assessment and treatment for the presence of protective responses. So you have to monitor the patient. The tester or the assessor has to look at the patient response. So maybe the maximum is 3, right? Something like that. You can argue for or against that. If you want to consider technical efficiency for the practitioner, you want to consider that the further away the practitioner is from what they're working on, they are using more effort. If they are using more effort, they are more likely to cause challenges to themselves, and they are, you could argue, less likely to be as accurate to their goal as they'd like to be. So there's a little bit more gray area there, totally acceptable, or acknowledged rather. It's acknowledged that that's the case. But you could monitor things like this. If you want to figure out whether somebody is assessing and reassessing appropriately well, you want to make sure that they're checking reasonable ranges of motion, they're not shortcutting tests, and you can observe that. You want to make sure that their pre and post assessments to show that there is change in movement are the same. If they are not the same, then you cannot believe it with respect to validity, because if you measure something with a stopwatch the first time and a ruler the second time, there is no validity. You are not measuring the same thing, right? So we've got challenges there. This can be done. You can figure out how to assess these things. With respect to the competencies in osteopathy, often they are happening at such a similar time that they can be difficult to pull apart. And when you test them individually, you get some level of confidence that the person can do them individually, but it's out of context. So often what I would argue for is testing target performance, which is assessment and treatment and reassessment. Within that, you will have your patient communication. So you can essentially be judging these things or assessing these things all the way along. So that becomes one of the challenges, is how do you assess them all in an integrated manner where you can have a higher level of confidence that a learner or a prospective practitioner is actually doing what you need them to do, not necessarily getting the best outcome, but working safely and gathering information from a patient in a reasonable way, with the acknowledgement that there will be holes in what they find or what information they request, because you can't be perfect in every situation. You will commit errors. Again, it's a question of how many errors are okay and how many errors are safety issues. So you would have to set a floor. Your floor would be 0 rather, but you have to set kind of a maximum of safety issues. But realistically, with safety issues, it'd probably always be 0. So if there is one safety issue identified, then that's a fail, something like that. And you would also want to, with respect to proving public safety, see this over and over and over again. You would not want to argue for a single summative test to prove practitioner safety. You need to see it over and over again. There will definitely be people who can pass an exam with a great performance on a single day or at a single time point, and then will go on and commit all kinds of behaviors or commit all kinds of acts that may be less than ideal. So you need to see it over and over again. The more I see it, the more I trust it, the more I believe it. So that's where a competency-based approach requires more assessment across time to prove that something is what you say it is. So it improves validity because you're remeasuring it. It also improves reliability because you measure it over and over and over. The more you measure it, the more you trust that it is what you're saying it is, or that your observation is consistent. So okay, we've got competencies out of the way, we've got assessment of competencies out of the way, and some of the challenges there. The concept of regulation and education were present at the OIA conference, and that was by design, and it's a great thing. The concept of regulation, so some of the arguments that I heard, or maybe not even the arguments, but the general discussion that I heard is surrounding the term recognition, as well as surrounding stabilizing scope of practice. So the term recognition, straightforward enough. In order to be recognized by external things, there seems to be some desire within the osteopathic profession in Canada and worldwide, in varying contexts, to be recognized by entities outside of osteopathy itself. You can argue for that, you can argue against that. There will be people who are, so the term motivation may be more appropriate, but there's also locus of control. So you can use the term internally motivated. Those who are internally motivated are doing stuff for their reasons, not necessarily looking or requiring something outside of them to drive behavior or to drive towards a goal. Whereas those who have an external motivational style need some kind of push. They need some entity other than themselves to get them driving towards a desired goal or a desired behavior. You can also talk about locus of control. Those with an internal locus of control can be described as believing that their actions and choices have impact on their outcomes, whereas those with more of an external locus of control, and there's probably variation here, but more of an external locus of control, believe it is the choices and actions of things that are not them that impact their outcomes. So you're going to have a variance in any group between those who are more internally motivated or have a more internal locus of control and those who are more externally motivated and have more of an external locus of control. So these people are present in all groups to varying degrees, and they will almost always have arguments as a result of different fundamental describable motivational styles or loci of control. So there's going to be dispute between these people. With respect to regulation, the other argument, and just to note this, so there's the desire, and the desire is probably more in those with an external locus of control, and also those who think that that others within their group are less trustworthy than they would desire. Right, so that's another aspect of this. I don't have this perfectly wrapped up for thought or delivery, but it's worth considering that one of the reasons that you would want regulation is because you think other people aren't up to snuff, they're not skilled enough, that they're going to impact how others view you in relation to being related to the same term. So the term being osteopathic manual practitioner or osteopathy. So if there's a big variance in how people perform that, and you don't like the way the others perform it, and you think the way that you do it is the more appropriate way, then gaining some control over that would have some intrinsic value. So those are just parts of pointing out the discussion, but the recognition. So those with more of an external locus of control or external motivational style would probably want that recognition from others, while those with the internal styles, either internal locus of control or internal motivational style, probably don't care as much or don't want it at all. The other thing with respect to regulation, as far as arguments and discussions that I heard, was the stabilization of scope of practice, so that as a non-regulated professional, you don't lose things you're allowed to do. And then the argument in the positive direction associated with that is that maybe you would gain scope with respect to your ability to provide healthcare or interact with the public with respect to their healthcare. So I think that's a very optimistic argument. I am not sure of its value, but I just want to admit that it is something that is being spoken about as an attempt to sway those who would be against the regulatory process. What I'd like to say about the regulatory process with respect to what it functionally is able to do, it does not promote excellence. It promotes base level performance to be considered acceptable. Okay? So a regulatory process is to judge if a novice is at a level that is considered safe in relation to the general public. That level is not expert. Many people would like to talk about it as if it is, but it is not an expert level. Okay? So a regulatory process or a licensing process generates a floor. You must make it to the level of that floor with room for improvement above and beyond through a career. The regulatory process should not be considered something that promotes excellence. Okay? That is not how it functions. That is not what it's built for. It is built to protect the public from the practitioner. Therefore, it creates a floor. It does not get people to a ceiling. Okay? It's not how it functions. It aspirationally will be spoken of in that way, but it doesn't do that. What it does is it normalizes the floor, or it normalizes the requirements for people to get to the floor. I heard discussion around educational institutions and how there are variable, observable approaches to education and outcomes with respect to education, and that there is at least some noted desire to lean on schools with respect to how they educate. What I will say is that if there is a regulatory process, the schools that already exist have no choice but to hit it with respect to their outcomes, especially if you're moving in a competency-based direction. A competency-based or competency by design or competency-based medical education approach does not have our requirements. It has competency requirements. Competency approaches do not change the details of what is taught. It changes the details of how performance is assessed, especially across time and at multiple time points. So any document or any regulatory approach that lauds competencies and uses hours as proxy is not doing it in the spirit of what they are claiming they care about. So educational institutions, if there is any form of regulatory approach, their responsibility is to prepare students and learners to get to the floor. So once you set those standards, those educational institutions are either going to hit them and prepare their students to pass these exams and pass these standards, or they are going to fail and fold. You do not absolutely require any form of oversight on the educational institution because it becomes a market force. If your students cannot hit that floor, they are then going to spread that information and the educational institution will fail, right? That's what's going to happen. So I understand the desire to lean on educational institutions to behave in a particular way, but a regulatory process would do that, right? So you don't have to add another layer of administrative task to the educational institutions in order to get them to come up to snuff on the fundamental regulatory standards, because if they don't, they fall apart. The extra administrative task would be something as simple as asking for proof of curricular element, right? Proof of curricular element is performance, especially integrated hands-on performance with respect to a member of the general public. That can be observed. I understand how this argument can sound as if I would be in favor of running away from some standard or running away from proof. Well, if you don't have anything to hide, then you might as well show us your stuff. I understand how I can be looked at as saying that, and that's not what I'm doing. What I'm doing is suggesting that the required performance is observable and you can test it multiple times to see if it's actually there, as opposed to a one-off good performance. Most regulatory standards require a one-off good performance, with the assumption that the person has gotten there through a bunch of other hoops. The way that that is checked is administratively. It's words on paper and test scores, and those things can hide stuff. So it is more appropriate, while resource intensive, for a regulatory body to test people quite a bit, as opposed to offload that to the school. Offload that to the school systems, maybe a better way to say that. So the educational institutions, if there is a floor set, will have to hit them or they'll no longer function. The floor should include, in a competency approach, multiple tests by the regulator or the regulating body. Or at least that's what I would argue for, so that the regulating body can trust that the practitioner is performing at a reasonable level. The way that this is often done is multiple tests over a 1 or 2 day period. And I do not know that this is as valuable as some would like to claim it is. So I don't remember all of the details of the argument that a group of authors, Sandra Montero, so Dr. Sandra Montero being my thesis supervisor, Dr. Teresa Chan, and some other authors suggested something along the lines of a graduated medical licensing for medical practitioners, or MDs, within the Canadian context. Now, the osteopathic manual practitioner, that wouldn't work out as well, but you could change your assessment approach. So in that light of testing people across time and seeing if they're ready for a more complicated task in a safe way, could be done similarly with respect to, say, a regulatory body. A simple suggestion would be that during an educational process, the regulatory body would provide some form of assessment to students. So these students could show up and be tested at varying levels through their education. Regardless of the length of their education, they can present and be tested. Resource intensive, absolutely. Time intensive, yes. So it's not necessarily that it's a fantastic solution or a high utility solution, but it is something that would line up well with a competency-based approach. And also, another set of discussions that was had was labor mobility. Labor mobility with respect to variable jurisdictions. The OIA ends up being in a good place to talk about this because the jurisdictions have very different systems. They have different requirements. So the OIA is in a decent position to set a decent floor. If you're an osteopathic manual practitioner, and you can do these things, you can kind of go anywhere. So if all of these organizing bodies agree, this is the floor, we can test somebody and see if they can do this, test them a few times. Can you do it? If they can do it, then you can let them work within your jurisdiction, if they can provably do it. And there's ways to create portfolios across time, and there's ways to create those systems that are, again, resource intensive and challenging, but it can be done. So overall, I hope I have done a decent job of presenting some of the concepts, presenting some of the pros and cons, some of the amazing things that I saw or very good things, and some of the challenges that I can see with the discussions. There was a discussion around cognitive biases in diagnostics in osteopathy. The gentleman who provided that talk, Dr. David Garza, I had the opportunity to speak with him briefly and was just asking him if he had seen certain research around cognitive biases and medical diagnostics or clinical decision-making. I believe it was clinical decision-making. I get screwed up between clinical decision-making and clinical reasoning from time to time, or diagnostic decision-making as well. So those terms do coalesce in my brain, and I don't separate them extremely well. And while I know that that's the case, I still haven't figured out how the heck to fix that in my thought process. So I provided Dr. Garza with some of the information, and he was interested. And one of the things I was talking about was medical error reduction. And he noted that usually when he provides that talk, he has many slides on a systems-based approach to reducing medical error, which is actually exactly what my research for my thesis popped up when I realized I had to look into medical error. So medical error is reduced by increasing expertise across time, as well as systems-based approach or team-based approaches where all members of the team tend to do the same things in the same order, such that if one member of the team makes a mistake, another member of the team can see it and provide them with the feedback, and they know how to correct it. So Dr. Garza was receptive to that, which was wonderful. So there also was a gentleman from the University of Quebec at Montreal, or UQAM, and because my French is poor, I may not necessarily be saying the name properly or translating it properly, but it's UQAM, Francois Lalonde. So Francois is finishing up his health science education in Montreal, and he was speaking very much to the concepts that I've been introduced to with respect to health science education and medical education generally, or HPE, health professions education. So he is in a very good position to translate a lot of that knowledge into the osteopathic profession and the osteopathic educational realm. And I find that very, very heartening. I find that very positive, because somebody who is attached to an institution, unlike myself, and is developing the skills to understand those things and those approaches, is actually going out and doing it. I hope to have some conversations with Mr. Lalonde or Monsieur Lalonde in the future. We've exchanged some information, and I hope to have that conversation with him, because I think it will be very positive, if for nothing else than my own desires. Hopefully it'll end up being something positive for the profession, where maybe I would be able to add some insight because of some of the ways that I have I've translated my knowledge into a teaching approach, and we'll see where that goes. But overall, I just wanted to say some positive things about the OIA OAO conference, that I was pleasantly surprised by a lot of the discussions, especially on the technical side, that things are going in a direction. The people who are interested in regulation are saying the right words with respect to what a government regulator would want them to say. And you can think of that what you will. They are prepared, they're motivated. So we'll see what happens. But with respect to competencies, I think that I have some things to add to the pool, and hopefully I get the opportunity to do so. So thanks for listening this far. Hopefully you learned something, and we'll talk again soon.